arthroplasty is a well-established procedure with higher survival rates as outlined by most of the joint registries worldwide. However, we as surgeons tend to concentrate on reporting performance indicators rather than health outcomes. Now, public health has recognized that problem and is shifting towards patient-performed outcomes over the last 2 decades. Of interest is that specific patient-related factors that determine the success of total knee arthroplasties mainly remains unknown until today. Oops. For a rating system to be used, it has to include a minimum number of criteria. One is it has to assess the pain, it has to report in function and range of motion, it has to summarize the outcome as a single score on a global scale, and that's been known for quite a while. In addition, the system has to be developed, reliable, responsive, and specific for a population. So a system that has been developed for Caucasians in Europe does not necessarily reflect the outcome of the Asian population in Asia. In addition, it has to be easy to administer and to complete. It should be economical, possibly even postal, and there must be data for normal populations. Now, interestingly, only 4 systems fulfill these criteria: the Knee Osteoarthritis and Outcome Score, KUS, Oxford Knee Score, Knee Pain Scale, and the SF-12. So the aim of this project was to investigate the relationships between outcome scores, commonly used subjective and objective outcome measures. 25 patients were included with an average age of 68 years and a minimum follow-up of 24 months. Mobile bearing knee was used in all cases, and all cases were navigated. So the usual scoring systems were used. We concentrated on isokinetic quadriceps peak torque, used the timed up and go test, and measured instability with EKD 2000. Descriptive analysis was used, and Pearson's product was used to correlate the findings. A sample size calculation was performed, and in case we did find larger than 0.5 relationships, which were not significant, we used post-hoc contrast to determine power and not to underpower and administer type 2 error. This slide is busy, but it basically shows you that the results of all our parameters were within normal limits. Here are the relationships between the scores, and as you appreciate, there is no significant relationship between any of the scores. The Knee Society score does not have any significant relations to the other parameters. The Knee Society functional score does not have any relationships to the other parameters. The Oxford Knee score does not have any relations to the other parameters. The KUS does not have any significant relationships to the other parameters. And finally, the SF-12 does not have any relationships to the other measured parameters. So in summary, we did not find any significant relationships between the scores. We found weak but non-significant relationships between the scores and strength. We found strong but non-significant relationships between scores and timed up and go. We found weak to moderate but non-significant negative relationships between the scores and the KD 2000 measurements. So as mentioned before, variable definitions of outcomes has been used, and we as surgeons tends to focus, especially in arthroplasty, tends to focus on performance indicators such as survival rates of our prosthesis. No consensus has been reached until today, and just to remind you, the Knee Society score is very commonly used to report outcome but has not been validated. The only 2 validated scores are the KUS and the OKS. So in conclusion, the scores and objective and functional tests measure different variables of outcome. Patient perceived outcomes have a significant correlation to knee biomechanics such as kinetics and kinematics. One of the possible explanations is the fact that all these scores do report pain relief, quality of life, and ability to perform activities of daily life, but do not report functions. And patients may be subjectively happy, but their objective outcome may not be as good as we think there is. So what is the future? The Royal College has proposed that for quite a while now. We should actually have a database which is accessible and available to everyone doing research or doing knee replacements or total arthroplasties. All future studies should include multiple instruments, and only valid and reproducible instruments should be used in research and in clinical practice. Thank you.